I did first a residency in pediatrics and internal medicine, and then I did a combined adult fellowship in adult pulmonary and pediatric pulmonary, so partly at Duke and partly at UNC, because UNC was where I did my research. And so I actually grew up in Denver and have been back in Denver since 2009. And so I know this isn't technically required for this presentation, but I did want to make everybody aware that because I'm the TDN director and I do a lot of clinical research, I actually get asked to be on advisory boards a lot as well. And more recently, I think because the research climate has gotten so much more complicated in CF, they've started to ask some of us in academics to help advise them about how to design their trials, basically in the setting of the fact that there are multiple modulators now that are approved. And so I'm on advisory boards for clinical trial development as described here on this slide. In terms of the outline, I know Laura said I had about 30 minutes, and it should take about that, and then you can ask questions, interrupt me in between if you want to, that's totally fine. But I just wanted to make sure that we were all on the same page in terms of modulators. I realize this is a pretty savvy group, but I'll go through that part quickly. And then I want to talk about the safety of stopping modulators, which has come up a lot recently. There are only a few case reports in the literature, but it's actually something I presented about during the TDN meeting at the North American Conference in October. So then I'll talk about fertility and pregnancy in general in women with CF, and then how those things are impacted by CFTR modulators, at least what we know right now, which isn't a ton, as I was saying at the beginning of this call. So in terms of modulating CFTR, again, most of you are probably aware that what we're trying to do with potentiators like Ivacaftor or Kalydeco is to improve the conductance for those chloride channels that are already at the top of the cell. So it can't be something that doesn't actually make it to the top of the cell. It already needs to be present there and just not working. And then Ivacaftor will make it open or work better when it's already there. With correctors like Lumacaftor, which is one of the medicines in Orkambi, or Tezacaftor, what we're trying to do is get those proteins that aren't usually up to the top of the cell surface to get there. So for example, with F508del, that protein is severely misfolded, and so most of it is discarded by the cell and never makes it to the top of the cell to function as a chloride channel. So a corrector is supposed to move that protein to the top of the cell. What we found out in the very early studies of people who had 2 copies of F508del is that it's not enough just to get it to the top of the cell, because even if you get it there, because it doesn't work very well, again, it's misfolded, it still needs something else to make it work better. And so that's where the combination therapies came in. So one corrector to get it to the top of the cell, the second drug, Ivacaftor, the potentiator to make it work better. So combination therapies that we have approved right now obviously are Orkambi, which is Lumacaftor, Ivacaftor, and Symdeko, which is Tezacaftor, Ivacaftor. And the triple combination, which of course yet is not approved, but the idea is to use 2 correctors and a potentiator. So available modulators in the US, because it's very, very different, as some of you are probably aware, outside the US. So we have Ivacaftor for these mutations, 38 mutations. We have Lumacaftor, Ivacaftor, or Orkambi for people who have 2 copies of F508del, and then Symdeko or Teziva for people who are either homozygous for F508 or who have F508 and a residual function mutation. So a mutation that actually responds to Kalydeco in the lab, or we know from clinical history that people have pancreatic sufficiency, so that they have partial function of their chloride channel. So those are the indications right now that we have in the US. So I just threw this slide up here because I wanted to make sure that everyone was aware of what all the fuss was about, which again, I think you guys probably know, but I think it's also really important to realize the relative improvement that you see with these different drugs. So on the far left is Ivacaftor for people with G551D, and the bar shows, the y-axis is an absolute improvement in percent predicted FEV1. So for people who had G551D and got Ivacaftor, their average improvement was 10.6%. If you looked at other mutations that were similar in their dysfunction to G551D, there was an improvement of around 7.5% with Ivacaftor, and then about 5% on average for people who had R117H. Now moving over to people who had 2 copies of F508del, if you look at Orkambi, it's a 2.8% improvement on average. There's a 4% improvement with Symdeko. And then based on the phase 2 data, in the preliminary phase 3 data that was released for VX659, we're looking at improvements of around 13.7% if you consider the Tez-Iva plus the triple, and then 15% for 445. So these are improvements in lung function that are even better than what we saw with Kalydeco in people with G551D. Now looking at people who have F508del and a residual function mutation, so for Ivacaftor alone, the improvement was about 4.7%, about 6.8% for people who went on Tezacaftor, Ivacaftor, or Symdeko. And then finally looking at those people right now who have no approved therapy, so have one F508 and a minimal function mutation. Again, we're looking at, with triple combination, based on the phase 2 data, improvements of almost 14%. So again, better than what we saw for Ivacaftor and G551D. And the reason I wanted to point this out is because I want to talk about how quickly this goes up in 2 weeks, basically from the trials, and then, you know, it falls off really quickly. And so what are the implications of that when you have such a huge improvement and then you stop a therapy that gave you such a huge improvement? So that's just context for what we'll talk about a little bit later. So let's start to talk about now about fertility in CF. So unlike men with CF, female patients with CF usually have normal reproductive anatomy. But there are factors that can affect fertility in women with CF, including thick dehydrated mucus. It's the same thick dehydrated mucus you have in your airways and in your gut. There's also a pH imbalance, because we always talk about the chloride channel, but that channel also transports bicarb. And so if you can't transport bicarbonate, then you can have more acidic secretions than you normally would. And it turns out the sperm need a more basic or alkaline environment to work really well. So thick dehydrated and pH imbalanced cervical mucus can decrease fertility. Other things include delayed puberty and ovulation, things Dr. Raksha Jain's really interested in studying, and then suboptimal nutritional status. So a really low body mass index can make it more difficult to get pregnant. That all being said, most women with CF who want to can become pregnant. There actually was a recent study that actually is still only in press and not actually published yet, that I just found in looking up things for this talk. And there was actually a reported rate of 35% of subfertility, so women who weren't able to get pregnant with CF. And the things that seemed the most problematic were pancreatic insufficiency, which could sort of be a mirror for severe mutations, but also older age at first attempt, which we also know is the case in the non-CF population. So the women who had a harder time getting pregnant were those who were in their 30s when they first started to try, versus those who were in their late 20s when they started to try. But the other thing to keep in mind with all of this is that, again, most women with CF can become pregnant. And if you look at different studies, again, there have only been a few, but between 25 and 49% of pregnancies in women with CF are unplanned, because oftentimes there are people who are told when they're younger that they're going to have decreased fertility and then don't make take the precautions that they need to avoid getting pregnant. And then changes in their health status can make a big difference too, as we'll talk about in a few minutes. And I just put this up here because I think most of you guys are aware, but again, most men with CF are infertile, and that's because of congenital bilateral absence of the vas deferens. So they're actually born with plenty of sperm, but they can't get the sperm out because the tubes never form. And that's very different than what happens with women with CF, because you do actually still have formed fallopian tubes if you're a woman with CF, as opposed to men who are born without the tubes they need for reproduction. So let's move on then and talk a little bit about how modulators interact with fertility. So if you look at animal data, so every new drug that's going to be eventually sent to the FDA is required to have animal testing. So if you look at the data from rabbits and rats, there was no adverse impact of Ivacaftor, Lumaiva, or Tez-Iva in animals on fertility. But then going into the real world with people, there was actually a thought that Ivacaftor may increase fertility because of either improved general health and nutrition status and or decreasing the cervical mucus tenacity, because the whole idea is that you're going to improve that chloride channel function, you're going to have more thin secretions in your lungs and in your gut. That same thing can hold true, or it was thought possibly, for cervical mucus. And one of the things that I don't know was talked about all that much at the time of the Ivacaftor trials, but 2% of the women with CF who were in those trials actually became pregnant during the Ivacaftor trials. And this, for those of you who are participated in some of the subsequent trials, is why there is such strict restrictions on what contraceptive method you can use in these trials, because they were alarmed by the fact that 2% of the people who were in these trials got pregnant unexpectedly. Then there was this survey that was published in 2017 that they actually went across all of Europe, the UK, Australia, even some people in the United States who participated in this CF Mothers group. So more than 500 women in 16 countries. And of those who responded, there were 12 women who reported 13 pregnancies after starting Ivacaftor. 7 of those 12 women had reported previous infertility. So in other words, they weren't able to get pregnant after 12 months of unprotected sex or pregnancy through reproductive assistance. So 7 of those women became pregnant even though they'd been told or experienced that they could not get pregnant previously. And the average time to conception after starting Ivacaftor was only 3 months. So this wasn't a long period of time that they were on drug before they got pregnant unexpectedly. There were also women that reported normalization of irregular menses and marked changes in the consistency of their reproductive tract secretions. So the hypothesis about decreased cervical mucus was very true for some of the women that responded to this survey. And then if you look through some of the case reports in the literature, there are 3 that I found. So the first one was a 35-year-old who was heterozygous for G551D, had a history of infertility, pretty good lung function and BMI, and had prolonged amenorrhea after starting Ivacaftor and was found to be pregnant when tested. There was also a 27-year-old who, again, had pretty normal lung function, nutrition status, but a history of infertility, and then became pregnant unexpectedly 3 months after starting Ivacaftor. And then a 20-year-old who had been sexually active and was using combined oral contraceptives to prevent pregnancy, but then for unclear reasons, it doesn't say in the report, she stopped taking them, started Ivacaftor, and then 5 months after starting Ivacaftor and stopping her OCP, she became pregnant. So clearly, for Ivacaftor at least, it definitely could increase a woman's fertility. And then looking at the question of contraception. So with the first drug, Ivacaftor, that was studied, there wasn't any expected impact on hormonal contraceptives based on all of their drug-drug interaction studies. So while in the studies you were not supposed to get pregnant, there wasn't any advice about avoiding oral contraceptives or any other kind of contraceptive with using Ivacaftor. In complete contrast to that, which I think made it a little bit confusing for some clinicians and CF center staff, as well as people with CF, was the fact that that was an opposite recommendation for Lumacaftor, Ivacaftor, or Orkambi, because based on the drug-drug interaction studies for Orkambi, there was actually decreased contraceptive exposure when used in combination with hormonal contraceptives, and that's whether it was oral contraceptives, injectable contraceptives, or theoretically implantable or IUDs that elute hormones. They said strictly that you have to use another form of contraception with Orkambi. And in fact, people's menstrual cycles were also impacted, probably because of the interaction with hormones, with Orkambi, although not with Ivacaftor alone. Because that became such a big issue and a lot of discussion was had about that, when they went to go test Tezacaftor, Ivacaftor, they actually were really, really careful about looking at drug-drug interactions. And as with Ivacaftor, did not show any interaction with hormonal contraceptives. So the only one that's currently approved that requires a non-hormonal contraceptive is Lumacaftor, Ivacaftor. And again, that's based on their drug-drug interaction studies, not because they did a formal test and formal study in human women with CF or any other diseases. They actually just looked at the drug-drug interaction studies to predict these abnormalities in exposure to hormonal contraceptives. And I will say with a caveat that the party line from Vertex is that you can't use a Mirena or hormonal IUD, but if you talk to most OBGYNs, they'll tell you that the method of an IUD is not because of the hormones that are released, but rather the mechanical method of an IUD. So we do actually have some women who have maintained their Mirena IUDs instead of switching to copper for commercial use only. If you're in a study, they still will make you have a copper IUD rather than Mirena. What about contraceptive use in women with CF? Again, as we were speaking about at the very beginning of this call, this isn't a topic that's been studied very much in women with CF. Many of you know Dr. Godfrey, and so she's been very interested in that topic and actually conducted a survey of women with CF, University of Washington, here at National Jewish, and at UC Southwestern to ask about contraceptive use in women with CF. And what we found was that the majority of people who were using contraceptives said they were using condoms or a combined hormonal contraceptive method, which of course is not important if you're using Ivacaftor or Tezacaftor, but if you're using Lumacaftor, it's really important that you use a different method. One other thing that we noticed was that among contraceptive users, the use of long-acting reversible methods like IUDs increased from 25.6% to 31.6% in the period that we were looking at. And that's probably, our guess is because of the modulators. Now, I showed you earlier a picture of a half man with CF, and that's a picture that's been used over and over and over again in CF. It was in Mike Knoll's article from a really long time ago. And so when I got interested in this topic, particularly around the use of modulators and pregnancy, I actually asked an artist at National Jewish to redraw that picture showing a pregnant woman. So this is just the same picture, but showing, of course, that the woman is pregnant and her fetus will be an obligate CF carrier, and that she still has the other issues that go along with CF in addition to being pregnant. So in the past, it was thought that most women with CF wouldn't really consider pregnancy. That probably wasn't as true as people thought, but it's definitely less true than it was in the past, because again, as people are living longer, healthier lives, I think a lot of people, and many of you guys can comment on this later, are more interested in having children, whether that's having children of their own, becoming pregnant, or adopting. I think that's something that's become a reality for a lot more people over the last 10 to 15 years. So in terms of a desire of women to become pregnant, it actually has been studied a couple of times, not a lot. But there was a retrospective study in Europe and the UK of 605 women who were over the age of 18. And this was part of that study I was talking about earlier, where they actually showed 35% of the women not being able to get pregnant. So they looked at their group of 605 women across all these different countries. Almost 40% of them had attempted to become pregnant. And then Tracy, who you guys know very well, also surveyed women, but these were younger women, and asked them about whether or not they were thinking about getting pregnant later in life. And 78%, so almost 80% of the young women said they wanted to have a child in the future. And whether you looked at these age groups by the 15 to 18 age group, the 19 to 21, or 22 to 24, the majority of women said that they wanted to have children in the future. So as I was trying to say to Vertex like 10 years ago, this is a really, really important issue, as you guys are really well aware of. So what's happened over time in women with CF around the world? So I emailed registry coordinators from a couple of different countries and got some responses. So this is looking at pregnancies in women with CF in Italy. For some reason, there was a peak in 2011, but overall, it's been pretty steady there on average. If you look in France, there's actually been a relative increase over the last 10 years compared to the previous 10 years. And then if you look in the UK, there's also been an increase over the last couple of years in the number of women who've had babies. And then looking at the US, there's definitely been an increase over time in the number of women who have had babies. So one of the questions that Sonia Helchi and I asked, again, because of my interest in how modulators were going to impact fertility and pregnancy, we looked at the US patient registry to figure out whether or not there had been any impact from use of the drugs or from the clinical trials on pregnancies. And you can see that along the y-axis is a number of pregnancies per 1,000 woman years, and then the decade is along the x-axis. And then we put in lines for where the trials occurred. And so you can see that there was a drop-off. It seemed around the time of the trials that later went up. I mean, this wasn't statistically significant in this group because it's a pretty small group, but there was definitely a decline that peaked later. And then we started to see this decline in women who were homozygous for F508 during the time of the phase 3 trial. So we definitely felt like the whole modulator era was impacting pregnancy rates and how people thought about pregnancy. And then just talking about outcomes for a minute, because if we're going to think about how a drug impacts outcomes of pregnancy in women with CF, we need to know how pregnancy impacts CF in the first place. And there have been a few studies on this, all of them retrospective, none of them prospective. So in other words, going back in time and looking at records. So Patel and colleagues used a really big national database. So they studied the outcomes of about 1,000 pregnancies in women with CF. And they did show that complications were more common in women with CF than without CF. So diabetes, which isn't a big surprise since many adults with CF have diabetes. There's also a higher rate of infection, again, not surprising because of the risk of exacerbations, and then a risk of preterm labor that was higher. But all of these occurred at a relatively low rate, even though they were higher than in women without CF. And then Mike Schechter and colleagues used a large CF study to look at outcomes in women with CF who did and didn't become pregnant. And what they saw was that compared to women who did not become pregnant, mothers had more illness-related visits, more pulmonary exacerbations, and a decrease in some domains of quality of life. Although I suspect that in the short term, that probably happens in women without CF as well, because having a baby is challenging in the first few months of life because of lack of sleep. Pregnancy and motherhood, importantly in their study, did not appear to accelerate disease progression on average for the women in those studies. There are some women who do seem to have an accelerated course, and there's not really any way to predict who those people are going to be, but on average, most women appear to do relatively well with pregnancy. And that's for women with lung function above 40% predicted. So if your FEV1 is below 40% predicted, it isn't recommended for you to become pregnant because those women do have significantly increased complications, both for themselves and for their babies. So what were the obstetrical complications that they saw? So this is a long list, but I highlighted the ones that I think that are most important because they were the ones that created the biggest odds ratio for more risk. And those were gestational diabetes, which of course can lead to large babies, which can lead to problems with delivery, and then preterm labor. Those were the two highest risks for women with CF versus those without CF. So what about medication safety in general in pregnancy? So most of the medicines that we use in CF for routine care, we don't think contribute to significantly more fetal malformations. Most of them are pretty safe in pregnancy. But the general principle, with or without CF, for a woman who becomes pregnant is to avoid drug use where possible, except for when the risk of the drug is outweighed by the risk of the condition that's being treated. So there are some situations where there's such a severe disease that it's much more important to treat the disease than it is to worry about the side effects of the drug. So it's a balance. And there were two recent reviews for anybody who wants to go through and look at all the different drugs that have been looked at and whether or not they're risky during pregnancy. Both those reviews are pretty thorough in their look at different CF treatment regimens. So I said you have to weigh that balance. So is it safe to stop modulators? So this is a study that was done by Dutch and Nicole, and what they were asking, and I realize this is about clinical trials, but I think it's relevant just for the general discussion, is whether or not people with CF thought it was okay to stop their modulator and whether or not their doctor thought it was okay to stop their modulator. And what you're looking at is people's willingness to participate in a clinical trial along the y-axis and how long they're willing to participate in that trial where they have to be off their modulator along the x-axis. And this first graph is looking at a treatment that is not inferior to Ivacaftor. So it's just as good as Ivacaftor. And so physicians said 2 weeks is probably okay, 4 weeks, and then as you get further out, they're like, no, you shouldn't stop your modulator. And people with CF thought, 2 to 4 weeks is probably okay, but the farther you got out, they didn't want to be off their modulator. And if the treatment was superior to Ivacaftor, People were willing to stay off for a little bit longer, but certainly most people said no way to 6 months. And of course, pregnancy is 9 months. And then looking at Lumacaftor, Ivacaftor, again, we're looking at physicians here in the gray, and then people on Lumacaftor, Ivacaftor in black, and then in white are people who have 2 copies of F508 but weren't receiving Lumacaftor, Ivacaftor. And you can see that people who were on drug really didn't, there weren't a lot of people that wanted to come off their study drug for really any period of time. People, when their physicians were asked, the physicians were like, oh yeah, sure, it's fine to stop. But the people with CF did not agree with that assessment. And then if you looked at whether the treatment was superior to Lumacaftor, Ivacaftor, again, people were willing to come off for a little bit longer. But again, when you got to 6 months, most people did not want to be off their drug for 6 months or longer. And again, pregnancy, of course, is 9 months. So this is a really busy slide, but I bring this up because I think it's important to figure out whether or not it is safe to come off modulators. So this was a study that was run by Dr. Jerry Nick here at National Jewish, and he was looking at people who have residual function mutations and treating them with Ivacaftor, because at that point, it wasn't clear whether or not those mutations would respond to Ivacaftor. So people either got randomized to Ivacaftor or placebo, and then they washed out and they went back on Ivacaftor or placebo, and they did this throughout this study period. And what we saw, and again, looking at why the change in FEV1% predicted on the y-axis, so people got drug and their lung function went up. But during the washout period, which is what I really wanted to focus on, people's lung function didn't necessarily recover back to baseline after they stopped their Ivacaftor. So this gave us some suggestion that there may be some risk after you've been on Ivacaftor for a period of time to just stopping it all of a sudden. Then more recently, Dr. Trimble and so a group from UNC actually reported on 3 cases of people who had been on Ivacaftor for a long period of time. So if you look along the x-axis, this is the period of time that they were on Ivacaftor. And then for various reasons, sometimes insurance, sometimes just non-adherence, people were off their Ivacaftor. And you saw this really rapid decline in what happened when they were off their Ivacaftor. And unfortunately, in the case of this 3rd patient, she even actually died after suddenly stopping her Ivacaftor after having been on it for a really long period of time. And then there was a poster actually at the North American CF conference where they looked at people who were in the phase 2 triple combination trial. And what they saw was that people who were in the trial, who of course came off drug or placebo after they were done with the trial, they saw 70% of the patients experience a decline in their FEV1 up to 6 months after the trial. And they saw declines at a median of 11% for that period of time. They also saw people have pulmonary exacerbations. So within 4 months after the trial, particularly in people with lower lung function, they had more exacerbations, and some of them had to receive IV antibiotics, and some were actually hospitalized after coming off triple combination. So that's where you have to think about the balance between what is the risk to the mother for stopping a modulator and what's the risk to the fetus for continuing it during pregnancy. I'm not sure how many of you are aware of the FDA medication and pregnancy categories, but I thought I'd cover them just really quickly. So category A is when there are actually well-controlled studies in people that show no effect on the fetus with use during first trimester. So that's things like Tylenol, for example. Category B is when studies in animals haven't shown any risk to the fetus, but there aren't any adequate and well-controlled studies in pregnant women. For category C, there actually has been animal data that showed an adverse effect on the fetus, but there aren't any well-controlled trials in people, and there's some reason to believe that it may benefit the woman enough to take the risk of using it, even though those animal studies showed some abnormalities. Category D is when there is actually positive evidence of human fetal risk, so not just in animals, but human fetal risk. But again, there may be some benefit to the mother that's so much more important that you're willing to risk affecting the fetus adversely. And then category X is when there are studies in animals or people that showed fetal abnormalities, and there's positive evidence of fetal risk. And you have to really, at that point, decide whether or not a pregnancy should continue when you need to use that medication, because you know it's going to cause a problem for the baby. So really at this point, there's very little known about how these modulator drugs affect pregnancy outside of what I showed you. Pregnant women are excluded from clinical trials because they're considered an at-risk population, which is totally appropriate. And based on the animal data, they're pregnancy class B. So no adverse impact in animals, but there haven't been any well-controlled studies in women during pregnancy. So if you look at the animal data, so on the left, we're looking at pregnancy or risk to the fetus that causes fetal abnormalities or miscarriage. And so for Ivacaftor, even at really toxic doses to the animals, there were no effects on the fetus. And they didn't see any miscarriage, but it's unknown whether or not there's an effect for miscarriage or risk for miscarriage. For Lumacaftor, Ivacaftor, they actually didn't test it in combination. We knew what the risks were with Ivacaftor, which was none from the animal data, and they tested Lumacaftor alone. And again, at really toxic doses to the mom, not the doses that you would take on an everyday basis. They didn't see any significant effect on the fetus. With Tezacaftor, Ivacaftor, again, they tested Tezacaftor alone. They didn't do it in combination. They found that at maternally toxic doses, so again, really, really high doses, that not the doses that you would take on a daily basis, there was decrease in fetal body weight, and then there was some early developmental delay in detachment of the ears from the head and then eye opening. So those were the risks, but all those were, again, at really toxic doses to the mother. So what about in women with CF who have stayed on these modulators? So there are reports in the literature for Ivacaftor. So the first one was somebody I mentioned earlier who accidentally, got pregnant because she thought she was infertile, and then turned out that she was fertile once she was on Ivacaftor. So she got diagnosed with pregnancy late in her second trimester and had a healthy infant at 38 weeks. Then there was a 20-year-old woman who stopped her Ivacaftor when she found out she was pregnant. She had gestational diabetes and pancreatitis during her pregnancy, but there weren't any complications for the infants, even though the infant was actually exposed for that first 15 weeks. And then there was a 25-year-old woman who elected to stay on Iva while she was pregnant, and she had no complications during the pregnancy, and there were no complications with her baby. There is also one report in the literature of a woman who stayed on Ivacaftor and Lumacaftor, or Cambi, during her pregnancy. So she stopped her Lumacaftor, Ivacaftor at 13 weeks when she found out she was pregnant. But because she is one of those people who got worse off of therapy, she decided to restart. And so her doctors at UNC actually measured the amount of Lumacaftor in cord blood and as well as the amount of Ivacaftor in cord blood and in maternal plasma, because it wasn't really clear. We didn't have any data on whether or not it crossed the placenta. So this clearly demonstrated that it did, because you can see that in cord blood, you could actually detect Lumacaftor and you could detect Ivacaftor. It was also present in infant plasma in this case. They actually did look at pregnancy complications, and she didn't have any. And then, as I'll explain a little bit more about later, they checked the infant's eyes, and the infant had normal eyes, even though the baby was exposed during pregnancy and then later during breastfeeding as well. So because there was this paucity of data, and even after years and years of asking Vertex and the CF Foundation about possibly studying this issue, it didn't seem like that study was going to be imminent. So Dr. Ed Nash and I decided to try to reach out to center directors all across the world and ask for anybody who had stayed on their modulator during pregnancy for their doctors to send in de-identified information. So there's no way we can identify who these women were, but just identify, or just to send in the information about what drug they were on, whether or not they had complications during their pregnancy, and whether or not the infant had any complications. So this again is data that I presented last year at the European CF meeting. So at the time that I got that data collected, there were 8 women who decided to stay on their Lumacaftor or Ivacaftor during pregnancy. So their average age was around 29. They were all homozygous for F508del. Their average lung function was around 69%, and their mean BMI, or body mass index, was about 22. About a quarter of them had CF-related diabetes. So all women up to that point were on full dose of their Lumacaftor or Ivacaftor. There are some people that take half a dose because of side effects, but these women were all on full dose. The average time of use prior to their pregnancy was just over a year. And 4 of the 8 women were on Lumacaftor or Ivacaftor for all 3 trimesters. So 2 of 8 were off for the second trimester, but half of them stayed on for all 3 trimesters. Importantly, I think, because of what I talked about earlier with the risk to mom from stopping modulators, 3 of the 5 who interrupted therapy because they were worried about the risks to their baby ended up going on during later in their pregnancy because they got sick when they went off their Orkambi. So 3 of the 5 women had complications during their pregnancy. So 2 of them had worsened CF-related diabetes. But again, I mentioned earlier in the talk that that's a complication that we know happens to women with CF. So the doctors taking care of those women said that was unrelated to their Orkambi treatment. There was 1 woman who had pericarditis or inflammation around her heart that the doctor thought was unrelated to her Orkambi. There were also 3 out of the 5 women who had complications after the pregnancy. 1 had a sustained drop in her lung function, but they didn't think that was related to her Orkambi. And then 1 had acute myelocytic leukemia. The doctor actually said he or she thought was related to Orkambi, although I couldn't find any other reports in the literature about Orkambi causing acute myelocytic leukemia. So that's an unclear relationship, I think. There was 1 infant who had complications. The baby had to be induced at 35 weeks, and that was because of mom's heart inflammation and her fluid overload. So that one was deemed unrelated to Orkambi. And then 2 of 7 women, infants had complications after birth. 1 had an elevation in their liver function test that they thought was unrelated to Orkambi. Obviously, that's a common thing that occurs in babies. Lots of babies can be jaundiced after birth, and this baby's resolved. And then there was 1 incidence of hypospadia, so change in the foreskin that was thought to be unrelated to Lumacaftor, Ivacaftor. So the last thing I was going to talk about just briefly is the effect of Orkambi or other modulators on lactation. So one thing I put in here related to the lactation and breastfeeding is the impact on eyes. And so this is important because when they gave juvenile rats, so 7-day-old to 35-day-old rats, they observed cataracts in those rats. And so that was a warning label for use of Ivacaftor in children. And actually what's happened over time with those reports is that in children with CF who've been exposed to Ivacaftor or Orkambi or to Symdeko, they actually have seen non-congenital cataracts, so cataracts that could have been caused by their modulator. So that's the reason I bring it up, because there is theoretical risk for the baby if the mom is taking one of these modulators during her pregnancy. In terms of lactation, in the milk of breastfeeding animals, they saw all 3 of these drugs. And then as I showed on the other slide, from that woman who stayed on her Orkambi during her pregnancy and during breastfeeding, they actually did detect it in breast milk. So the infant will definitely be exposed both through cord blood, and if mom continues to take drug while she's breastfeeding, the baby will be exposed based on both the animal data and this data that was published in a woman with CF. So from the data that I collected, there were 2 women who continued to breastfeed while they were on their Orkambi for a minimum of 5 to 6 months afterwards. And of those infants, one of them had had actual exam by a doctor to see if the infant had cataracts, and the infant did not have cataracts. So again, that study that I'm doing and the one that Dr. Nash is doing on Ivacaftor in women with CF and pregnancy is a retrospective study. And it's, obviously very limited data because we're using anonymous data. There's no way to follow up with any of those people because they're not identified in any way. So what Dr. Jane and I really think needs to happen, and you guys of course can discuss this during your portion of the call, is that we really think that we need more data on this issue. So we can use the CF Foundation patient registry, but unfortunately at this point, there's very little data about pregnancy that's collected as part of the registry. So the question for the end of the year data entry is, was the patient pregnant during the reporting year? And so then you answer yes or no. So it doesn't even ask anything beyond, did any of these things happen? So no other information can be obtained from the registry. So we could get a lot of information, but on a very, very limited basis. And the other issue in terms of studying the modulator effect on pregnancies is that I'm not sure how many of you are aware of what the data is that goes into the registry, but basically for Lumacaftor, Ivacaftor, Tezacaftor, it's like, was the patient on this medicine when they came in for their visit? And so it doesn't ask when it was started, when it was stopped, if there were any interruptions. And you guys are all well aware who are on modulators. I can write for a prescription today, and that may mean that you get it next week, or it may mean that you get it in 3 months after lots of prior auth. So even with the registry having lots and lots of data on lots and lots of people, there's still very limited information that we can glean. Not useless by any means, but just limited information. So Dr. Jane and I really feel like we need a prospective study so that we enroll women at the time that they are diagnosed with pregnancy, and then follow them over time to look at both the impact on their physical health as well as the psychological health of the woman with CF, but also on what happens with her baby based on her use or lack of use of modulators and other medicines during pregnancy. So just to sum up really quickly, obviously the number of women with CF who want to have children is increasing over time. But the data on modulator use and fertility, contraception, and pregnancy is very, very limited. So everything that's in the literature is what I showed you in those slides. We do know that use of hormonal contraception is frequent in women with CF, but you can't rely on that method if you're going to use it with Orkambi, so you have to use another method. We also know now that use of CFTR modulators, at least for sure with Ivacaftor, can actually increase fertility in women with CF. And then the small survey that I've done so far showed that people who stayed on their Lumacaftor or Ivacaftor during pregnancy, if they tried to stop, more than half of them actually got sick and had to restart their drug. And we didn't see any effects on the infants in the limited data that we've collected so far. And there was only one incidence of what the physician said he thought was a complication that was related to Orkambi, and that was the acute myelocytic leukemia. But again, there aren't other reports about that. So with that, I'll say thanks to all the women with CF who participated in these trials. Also the registry coordinators from Italy, France, and the UK who sent in their data, and the CF Foundation for their registry data. Obviously this group who is very, very interested in these questions and helping to influence the CF Foundation, hopefully to put more funding into this area. And there's a private donation from a family here who is funding the study that I'm doing. And then these are all the centers who sent in data for the survey study. So for those of you guys who actually attend National Jewish, you'll recognize most of these people. And then with that, I will take any questions.